Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear.
Hi there, Mr. Barry. Your GP has referred you to me to discuss your anxiety. So tell me, how have you been feeling?
Well, I'm still suffering from the anxiety and panic attacks, and the medication that I'm taking, I found that it seems to have some side effects and it makes me still feel a little on edge. So I found it better to take the medication at night rather than in the morning, and so I can get on with the day kind of thing, but I still feel quite anxious.
Okay. Getting used to the medications can be difficult. Going back, when did you start the treatment again?
3 weeks ago now? And that was the citalopram, the one to hopefully control the panic symptoms longer term, and the chlordiazepoxide, which is for the more short-term control.
How many of the chlordiazepoxide are you using a day at the moment?
Well, the doctor gave me 20 milligrams 3 times a day, but to be honest, I'm trying to cut them out. I only use them if I really, really need them.
Good. And do you feel okay with that?
Yeah, it's like I don't feel like they suppress me enough, if you get what I mean. I know that my main aim to tackle this is, to be honest, is getting fit and more exercise, because I know that's the feeling that I need to aim towards. Because I know from past experience that when I work out, I feel better, I feel more relaxed, etc. So I'm trying to work towards that.
So how many actually are you having at the moment?
Today, I've had to go into work just for a conference with my manager, just to discuss how things are going and stuff. So I had to take 2 because I just felt like I couldn't manage it otherwise.
Right, okay. So over the past 4 or 5 days?
None except for the 2 today.
So you've actually been laying off them altogether.
Yeah, I've been trying, and when I do take them, I only feel suppressed for a very short amount of time.
Right. Now, the citalopram medication...
Yes, I'm on 20 milligrams once a day, and the side effects, headaches, were quite bad to begin with, and I'm still getting them, but I think that could be more stress-related, because they're not I wouldn't call them painful headaches. I just can feel they're there. I also had a sore ear, so I wondered if I might just have an infection or something too.
Okay, we'll come back to that. But you're now taking the citalopram at night.
Yeah, I found that if I take it first thing when I get up, I still feel quite edgy, and also the side effects.
Yes, okay, right. Now, the reason you started the treatment was because you were getting full-blown panic attacks. Can you tell me a bit more about the attacks?
Yeah, well, I couldn't leave the house. My heart races and I really struggle to breathe, and I just feel an intense fear. It makes me feel sick and dizzy if I go out into the street.
You find it very difficult to get out and about. Are you beginning to normalize, do you think?
Yes, I've managed. I went over to the soup store on my own and I managed. I felt a bit jittery at first, but I've learned over the years after suffering quite severely with them years ago that you just have to take your mind to a different place, and I just concentrated on what I wanted from the shop. That was the first time I've been out on my own since I started on the medication.
You will hear part of a consultation.
You now have 30 seconds to look at the notes.
Morning, Sarah. I'm Dr. Neil Strathmore. I'm a cardiologist, and you've been referred here from the Royal Children's Hospital for some further follow-up. So why don't you tell me a bit about yourself and what's been happening to you?
Well, I was born with a congenital heart, and I've had surgery in 1991 to correct that. And I was also, a pacemaker was also put in, and I've been seeing my cardiologist at the Royal Children's Hospital since then, and now I've come here.
So in 1991, how old were you?
I was 6.
And how old are you now?
I'm 23.
And so you obviously don't remember much about that, but what did your parents say was the problem with you when you had the surgery?
Well, they tried to explain what it was, which was transposition of the great vessels, but basically they told me that I was out of breath, and that's why I couldn't keep up with the other kids, so I was going to have an operation to make me better.
Do you have any memory at all of the surgery or of being in the hospital?
Yes. I remember the nurses, and I remember the playroom, and I remember finding it really difficult to walk after the surgery.
And so do you remember the fact that you weren't able to keep up with other children when you were little?
Not so much, but I remember my lips turning blue and my fingernails being blue and basically going blue when I ran out of breath or running too much.
So after you'd had the surgery, did you only ever have one lot of surgery, or did you have to have repeated operations?
It was just the one in 91.
Good. And so after that, how did you get on in terms of your exercise capacity?
I didn't start off doing too much, but then afterwards I had been doing ballet beforehand, so I continued on with that. And then I picked up some more dancing, and as I got fitter and older, I was doing that quite consistently.
So during your teenage years, how fit were you?
Fairly fit. I was doing about 5 hours of dance a week, so...
Gosh, that's quite a lot, really. That would be quite tiring.
It was.
And so have you kept that going since you've left school?
I have, but definitely not as much because I've been busy with uni and things like that.
So how fit are you now?
Probably not as fit as I'd like to be, but I'm still taking classes and walking regularly.
So do you have any symptoms? Do you have any shortness of breath?
No, not really. I try to keep watching other people when I'm in classes and making sure that I'm not more out of breath than they are. But normally when I'm turning around, everyone seems to be as puffed.
So if you walk up a hill or walk up a flight of stairs, do you get short of breath?
A little bit, but not enough to be concerning.
So you think you're about the same fitness of other girls of your age?
I think so.
Okay. Now, what about your health otherwise? Do you have any other health problems?
No.
You've already said your breathing's okay. Do you have any cough or sputum?
No.
Any wheezing or asthma?
Not at all.
Your waterworks, do you have any problems with your urine or bladder?
No.
What about your bowels? They're all okay?
Yep.
And your appetite, and you don't get any nausea or vomiting or anything like that?
No.
And do you get any headaches?
Headaches I get every now and then, but I think that's mainly to do with stress.
Okay. Do you smoke?
No.
Alcohol?
Yes.
How much?
Every now and then.
So on an average week, how much would you drink?
It depends. Probably just once a week.
Mm-hmm. And would that be 3 or 4 drinks or more than that?
Probably no more than that.
Okay. What about recreational drugs?
No.
Not at all? Good. All right. Now, do you ever have any pain in the chest?
No, not at all.
Do you notice palpitations where your heart's beating fast?
No.
And have you ever had any blackouts or dizzy spells?
No, not at all.
Do your ankles ever swell up?
No, not that I've noticed.
Mm-hmm. Have you had any problems with excessive bleeding or bruising?
I notice I bruise quite easily if I just bump into things, but not enough to be too much of an issue.
Okay. Is there any family history of any heart problems?
No, not at all.
None of your parents or siblings had any congenital heart problems?
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear a doctor and a trainee discussing the application of a plaster cast.
So let's discuss the short arm cast that you're going to apply. What are the steps?
Well, first, I need to examine the area and check the x-rays to see if surgery is needed. For the cast, first I'll apply a stockinette with a hole for the thumb, and then I'll wrap the arm in a web drill for padding. After that, I need to immerse the roll of plaster in water.
Right. And what should you point out about the plaster?
I need to warn the patient that it may feel hot as it starts to set. How long does it take to dry?
The cast may feel dry to the touch in a few minutes, but it isn't fully dry for 72 hours. What's the last step?
After I've applied the cast, I need to take another x-ray to confirm that the fracture has been reduced.
You hear a manager explaining new data management processes to clinical staff.
Yes, in the back. You had a question?
Yes. How should we file our feedback reports? Do we need to just complete them on the computer?
That's a great question. Remember that since the clinic has begun transitioning to the new computers and software systems, we need you to fill out the paper reports in addition to the digital versions. I know this may be time-consuming, but this is because as we transfer all our files from the old servers to the new ones, some files may be misplaced, and we want to ensure that all of our records are easily accessible at all times.
So we need to make 2 copies of our reports?
Yes, exactly. Great. Does anyone else have a question?
You hear a presentation about the introduction of a new type of wound dressing.
Thank you all for coming. Well, after some research, the hospital has decided to invest in a new type of dressing to care for our patients with chronic wounds, such as those with diabetic ulcers. Although the traditional cloth compression bandages are useful, they need to be changed frequently to promote healing. These new bandages are made of a natural plant-based material instead. In fact, they're made from seaweed. Alginate dressings are somewhat costly, but they can prevent harmful strains of bacteria from entering the wound by forming a protective barrier with the skin. Most impressive of all, they can absorb up to 20 times their own weight, so they're the best choice for wounds with high-level exudate. Based on these factors, we believe that alginate dressing would be a useful addition to our wound care procedures.
You hear 2 hospital managers discussing completion rates for an online course.
It looks like only around 40% of the staff have completed the online health and safety course so far.
Less than half, but the course has to be completed by all staff members by the end of the month. Can we send them a reminder email?
We've reminded them by email twice already. I've even phoned a few people. I think we need to bring it up at the general staff meeting next week.
That's on Thursday afternoon, right? Will that work with everyone's schedules?
It should. All staff members have that time already blocked out. But if anyone can't come, then we can speak to them in person one-on-one.
You hear 2 colleagues discussing an online training course.
Hi Fiona, how are you? Can I ask you something?
Sure, Mug. What's up?
Have you done that online training for a new record management process?
Yeah, I did it on the weekend. It was supposed to take 10 minutes, but it took me ages.
Did you have any trouble with it? I mean, any technical problems?
Not really. I couldn't log in for a bit, but that was just me getting my password wrong. After that, it worked fine. Why?
I keep getting this email that says I haven't finished all the activities, and then when I log in, it says I've completed everything. It's driving me crazy.
Did you ring the IT help guys?
Yeah, they reset it, but it didn't do anything. I really don't want to do it again.
No, you shouldn't have to. Maybe just send the register an email and let her know that you've done it. Maybe she can fix the issue.
You hear an educator describing methods for creating medical abbreviations to nursing trainees. A technical name for the use of first letters is initialing, but I prefer to use the phrase the first letter rule for this method. Abbreviations using the first letter rule commonly identify diseases and diagnostic tests. For example, chronic obstructive pulmonary disease is COPD, or liver function tests are LFTs. In most cases, these letters are pronounced separately as letters, but sometimes key letters or key syllables form the abbreviation. For example, hypertension is abbreviated using HTN, or we see the term atrial fibrillation abbreviated as either AF or AFib. Sometimes the first letters form an easily pronounceable word, an acronym. For example, acquired immune deficiency syndrome becomes AIDS, or severe acute respiratory syndrome becomes SARS. Understanding these principles will help you to more quickly learn the many abbreviations used in local clinical settings.
Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Inducing labour, that's breaking a woman's waters and making the uterus contract more strongly. Is it safe? It's an important question, and a large randomised trial has found the answer, at least for some women. The lead author was Bill Grobman, who's Professor of Obstetrics and Gynecology at Northwestern University in Chicago. I spoke to him earlier.
What was being tested was the concept that for many years there has been a belief, really deeply ingrained, that labour induction leads to a greater chance of cesarean delivery. The truth is, though, that it's based on relatively long ago studies for which, and I'm happy to describe why, there has been a fundamental misinterpretation of the results such that we misunderstood the clinical implications.
Well, let's just talk about this misunderstanding. And just to be clear, when we're talking about labour induction, we're talking about breaking the waters and putting up a drip which makes the uterus contract.
When we're talking about labour induction, there's not a single way to do it, but that typically you're right.
So was the problem in the past that labour induction was done on women in distress and therefore it was a biased population? They were already in strife when they were induced?
Well, I think it's actually two issues. One is the issue that you already referred to, which is that so often women were being induced for a medical reason. Something else was going on. Either the fetus was in need of being delivered or the mother herself had a complication that led to delivery being recommended. And clearly those were both situations that led to a higher chance of cesarean. But the other really important thing was that the studies that were done, and when I say studies, I very much mean observational studies, not trials, but studies where people went back and looked at records of women who had delivered, where women who were being induced were compared to women in spontaneous labor at the exact same gestational age. And I think it is undeniable that if you make that comparison, that there's a greater chance of cesarean among women who were being induced than women in spontaneous labor at the exact same gestational age.
Why is that?
Oh, well, I don't know why it necessarily is, but it just is. It's something that's observed, something that when people studied it, not with the clinical trial, but with observational data, that happened, and very consistently.
But these are biased studies because they weren't randomized.
Let me put it this way. Induction of labor is an option. I can choose to be induced or not to be induced. Spontaneous labor is not at the exact same day is not an option. Women may spontaneously have a labor, but also may not. They may not go into labor for another 2 weeks, and every week that goes by, the chance of cesarean increases. They may not go into labor and get to a point where induction of labor becomes recommended, but now it's an induction 1 or 2 or 3 weeks later. And so if you're making a clinical decision, and the clinical decision is, do I choose to be induced now or do I not? The alternative is not spontaneous labor on the same day.
It's waiting.
The alternative is waiting, which may end up in spontaneous labor but may not, or may end up in spontaneous labor weeks later. And when observational studies were constructed like that, studies that reflected the actual clinical situation, you actually very consistently did not see the association of induction with cesarean delivery.
So now you've done a randomized trial where you actually get women and you randomize them to induction or waiting.
That's exactly right. So,
and this is in women who've never had a baby before.
That's right. And so that's, I think, an important point. Most of the concern with regard to cesarean delivery was with regard to women who had never had a baby before, women on their first birth. And I should also say this isn't about women who have medical complications for which there's a medical indication for induction. This was really a question of women who had no other reason, no standard reason to have induction recommended. Was it indeed true that induction would lead to an increased risk of cesarean, or might it be, as the more recent observational studies suggested, that induction didn't increase or even decrease the chance of cesarean and maybe also improve the outcome of their baby? And
sitting behind this is a concern about a high caesarean section rate, complications in second pregnancies. You're kind of condemning yourself or committing yourself to a second caesarean, and sometimes the babies don't do as well.
I think what we would say is that, for any woman who desires a vaginal birth, that we want to do everything we can to try to optimize that chance. And clearly, if someone can have an uncomplicated vaginal birth versus an uncomplicated cesarean, both in terms of short-term complications and long-term complications, including complications for future pregnancies, it's preferable to have a vaginal birth. What we want to get rid of are unnecessary cesarean deliveries that would have potentially preventable, and the health of the mother and her child or children are preserved.
Okay, so you took about 3,000 women, not a small study. Well, it's actually, 6,000 women.
Yeah.
3,000 were assigned to labour induction at 39 weeks, and 3,000 waited to see whether they went into spontaneous labour, and they were low risk, as you said. And your outcome was mother's health, baby's health, and caesarean section. Is that right?
Yeah, that's exactly right. It was 3,000 women in each group, low-risk nulliparous women or women on their first birth, randomized to induction at 39 weeks or expectant management or waiting. And not forever, because there's still an upper limit at which in the modern day is considered sort of acceptable practice, but till about 42 weeks would be the upper limit.
What did you find?
Well, what we found was that women who were randomized to labor induction had a significantly lower chance of cesarean delivery, so about a 15% relative risk decrease in cesarean delivery. Women who were randomized to induction of labor delivered babies who were significantly less likely to need extra respiratory support, like having a tube put down their throat to help them breathe or requiring high amounts of oxygen. Women who were induced had a lower chance of having high blood pressure problems at the end of their pregnancy, sometimes called preeclampsia. And also they reported less overall pain, and they reported a greater sense of control over their labor process and a greater sense of agency.
Well, that sounds pretty impressive. We'll come back to the implications in a moment. But one of the risks here is you get the scent of the patient.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Okay, my guest today is Pauline Davidson of the University of California. Dr. Davidson is here to discuss the findings of two studies that focused on the effects of a secret safe injection facility in the US. Dr. Davidson, thanks so much for agreeing to talk with me today. So, what was your big takeaway from your research?
One of the things people have said about opening safe injection facilities in the United States is that the US situation is fundamentally different from that of other countries where it's being used successfully. It's an argument that just because it can work in Europe or Australia or Canada doesn't mean that it'll work here. The big takeaway from this research and all the data we have so far is that these kinds of facilities have a similar effect here in the United States as they do elsewhere. They reduce harms associated with drug use, and they reduce social nuisance associated with drug use in the same way they do elsewhere. Basically, anywhere that you have a concentrated street-based drug scene involving a lot of fairly impoverished people using drugs, you get the same set of problems, and the people using drugs have the same set of problems. And these facilities deal with them quite well, whether they're in Vancouver or in Los Angeles and Skid Row, or any other area with a lot of drug use anywhere.
So, how did staff get this secret facility going?
This is an organization that was providing other services to drug users. They were in this really frustrating situation where they had a lot of people they provided services to who were dying of overdoses. After looking at safe injection rooms and how those work elsewhere in the world, they realized that if they waited for advocacy to legalize these facilities in the United States, all their people would be dead. So, after a good deal of discussion about it, they decided to implement something along these lines. Initially, they started by re-equipping their bathroom, so it was better suited to safe drug consumption. But that had too many logistical problems. They couldn't use the toilets because drug users were in there. They had a spare room available, so they refitted that. They modeled it after the Vancouver facility and opened their doors to a group of their longer-term users, and continued ever since.
What actually happens? How do they ensure safety and that kind of thing?
Well, it looks pretty much like an ordinary clinic. It's a fairly large room with 5 separate stainless steel injecting stations, and the staff are always in the same room as the clients. People come in, do a check-in on a laptop, sit at an injecting station, and prepare and then use their drugs. Then there's a couch if they want to sit there and wait for the immediate effects of the drug to wear off. The staff are trained to use naloxone and, if necessary, call 911. And since they're in the same room, they observe people injecting, and if they see some injecting practices that are less than ideal from a public health point of view, there's an opportunity to talk about that. So there's a number of benefits to having the staff member in the same room, rather than just overdose prevention.
What do users like about the facility?
Well, the biggest one that they kept talking about is how they're able to get out of the public eye, take their time, and use in a clean, well-lit space. People talked about using in the public eye and shooting up in a hurry between two cabs in the streets. They were very much aware of passers-by, not just because it's illegal. I mean, they're aware of the police, but because they're aware that it's not seen as a nice thing. They're particularly terrified of being seen by someone's children. So being able to get out of the public eye was very much a relief. So there's a serious benefit to their well-being, how they feel about themselves.
Did users have any complaints about the facility?
Mostly that it wasn't open 24/7. They really like the space, and they would like it to be open far more often. A couple of them also talked about the problem of how the organization couldn't closely coordinate or do referrals to other agencies because they were trying to keep this all in the down low. Users were quite aware of this. They were saying it would be better if this organization was really closely coupled with a treatment agency, and that handoff could be much better. The staff were also quite bothered by the fact that they had to keep the facility to a fairly small number of people and felt like they had to exclude people with mental health issues because they felt like including them would be more likely to lead to disclosure to third parties. So the organization couldn't serve a number of people who were likely at a higher need.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.